Thank you so much, ma'am, for that wonderful introduction. And thanks a lot for having me here today. So this is going to be the most dreaded topic for any eye care professional. It is managing ocular emergencies. It's something which we don't want to have in our daily practice. We don't want to see an ocular emergency, but inevitably, unfortunately, we will come across emergencies in eye care also at any point of the day. So the whole point of this 10-minute brief talk is to give an idea on what are the ocular emergencies. That's the first thing. Second thing is, if it's an ocular emergency, what is the diagnosis of that emergency? Third is, should you treat the patient or should you refer the patient? Or should you treat and then refer also? You know what I mean? So there are three aspects which you should come to our mind. Should I just treat the patient and have him as a follow-up? Or should I treat and send the patient, refer the patient as early as possible, or should I just send the patient to the tertiary eye care center immediately? That's going to be the whole concept of this. The way I'm going to present this is I'm going to present two mind maps so that you can easily understand and kind of encapsulate the entire concept. Because when it comes to vision care technicians, eye care professionals, even ophthalmologists, no matter who you are, it is important to identify what is the problem amongst the myriad of symptoms the patient is going to present to us. The patient can come with multiple symptoms. There can be a big, vast history. And you can have multiple diagnosis or a differential diagnosis for example, you have an acute red eye. You can have like multiple symptoms, right? So what is the cause of that particular acute red eye? Or what is the particular cause of that pain or blurry vision? That's going to be the important thing. So let me share the screen. All right, so I'm going to present on two important emergencies. The first emergency is going to be acute red eye. The second emergency is going to be a defective vision, which is sudden onset defective vision. These two will be our focus. Okay. Now, like Divya ma'am said, I have a YouTube channel where I do these lectures. So this is the name of the channel. It goes by my name, Pranesh Balasubramaniam. And when you go to this channel, you will see three videos. You will see three videos: a video on history taking, video on defective vision, a video on acute red eye. I strongly recommend the audience to go and watch these three videos. Take your own time. All these three videos come to around 2.5 hours to 3 hours, but it's worth the time. Under each video, for example, you go to this video on acute red eye, you go to the description box, you can click on this mind map. When you click on this link, it goes to a mind map where you can download whatever I'm teaching you, whatever mind map I'm presenting to you, you can download it for your future reference. So there are three mind maps on acute red eye, defective vision, as well as on history taking, three mind maps. So get them onto your phone or onto your computer, then watch these lectures along, you will have a better understanding. All right, let's quickly go on to acute red eye. Now, what is an acute red eye? Acute red eye means a patient is presenting to you with pain and redness, as simple as that. So along with pain, along with redness, the patient can have a defective vision or a blurry vision, or patient may not have a defective vision. So it's important for us to identify what is the important component of this acute red eye. Do you have a blurry vision or not? If the patient is not going to have a defective vision, which means that you can try to treat the patient. There is an exception. We'll come to that in a minute. But an acute red eye without defective vision, you can still wait. You can treat by yourself without referring the patient to the other bigger center. But what needs referral is going to be this: an acute red eye with defective vision. Now just think for a minute. You are seeing patients in your OPD every day. You will come across patients who have both painful red eye along with poor vision. What are the differential diagnoses? These are going to be differential diagnoses. First, going to be acute keratitis. Acute keratitis means corneal ulcer, as simple as that. Acute angle closure glaucoma. Acute anterior uveitis. Acute endophthalmitis. And finally, injuries, both chemical injuries as well as your mechanical injuries. Okay, this is going to be the causes of acute red eye with defective vision. So you need to memorize these. You need to remember all these things, because a patient coming to you with an acute angle closure glaucoma, okay, you might think it is an uveitis, but both are different entities. The treatments differ between these two similarly looking, similarly presenting condition. Now let's touch upon this. What are the conditions with acute red eye without a blurring of vision? If you can recollect, the causes would be this. The most common what you face every day is acute conjunctivitis. An infective conjunctivitis can be viral or bacterial. Anita ma'am discussed about that in detail. Allergic conjunctivitis, episcleritis. Rajati sister mentioned the importance of having a fundus examination in episcleritis, if you can remember that. Anterior scleritis, subconjunctival hemorrhage, foreign body, again quite common, epithelial defect of cornea. So these are going to be the important conditions where you have acute red eye without defective vision. Of these, if you can ask me, what should be one condition where you should refer the patient immediately, that will be anterior scleritis. Because scleritis will often mimic like an episcleritis or even conjunctivitis. But scleritis patients will have severe pain and you have to refer this patient as early as possible, because scleritis means there will be an underlying systemic condition. Yes. Systemic condition is equal to scleritis. It can be rheumatoid arthritis. It can be something joint pains, something like uveitis. So you need to refer the patient as early as possible. Now, I'll just quickly give you what are the important signs and symptoms a patient will present in each complaint, okay, in each diagnosis. So acute red eye with defective vision. Acute keratitis. Now imagine a patient coming to you with a corneal ulcer. What will be the signs? What will be the symptoms? What will the symptoms patient can come up with? Apart from that pain, redness, the one important complaint, which is quite unique to acute keratitis, and one more condition, we'll come to that in a minute. It's going to be glare, photophobia, painful sensitivity to light. A patient is saying, I'm having severe pain, redness with glare. Think about acute keratitis. History, when it comes to our Asian countries, the most important history to be asked is history of trauma. Trauma with an organic matter, like a stick. For example, farmers, when they carry the sticks with them, that can have a corneal ulcer leading on to a fungal corneal ulcer. In developed countries, what I'm seeing here in UK is that many patients are wearing contact lens even till 60, 70 years of age, and all of them will have contact lens induced keratitis. Contact lens induced corneal ulcers, which is much more common than fungal corneal ulcers, what I see here. So it depends upon where we are working. What are the signs you will see in acute keratitis? You will see congestion. You will see this redness. That's important. It's obvious. You will see a corneal ulcer. You will see something white here. Okay, that's going to be on the cornea. So it's a corneal ulcer. And you may see a hypopyon. What is hypopyon? It is a pus in the anterior chamber. You see this? You can see an ulcer, and you can see this kind of like a meniscus, kind of like a semi-circle collection of pus in the anterior chamber. All right. So far clear? This is acute keratitis. Acute angle closure glaucoma. It has been discussed previously. Again, I just want to tell that the one important symptom what angle closure glaucoma patients will present will be severe pain. Pain which makes them sick. They start to vomit because of that severe pain. Think of angle closure glaucoma. An important symptom which is extra, which I've not mentioned because sometimes patient may tell, may not tell. It's called as colored halos, which means when looking at a white light, the white light will be appearing like a rainbow colors, multiple colors. It's called colored halos. Let's look at the signs. Probably the most important thing you should look for is going to be two things. First, going to be a rise in intraocular pressure. Because I know that when a patient is going to come with an acute conjunctivitis, we will not check intraocular pressures. But always please rule out glaucomas, because for glaucoma to diagnose, you should take an intraocular pressure. Do this torchlight test. Even if you don't have a slit lamp, doing a torchlight test on the side can reveal a shallow anterior chamber, which is another important sign for an angle closure attack. A fixate semi-dilated pupil. You see the pupil here? The pupil is kind of semi-dilated pupil. That's an important sign. And most of those patients, when they come with a primary angle closure glaucoma, an angle closure attack, they may have a smaller eyeball. They can have hypermetropia because smaller eyeball, crowded anterior chamber, there's a risk of angle closure. And last but not the least, probably something which is very important is in our area, the place where we practice, we have lots of cataract, and cataracts are often neglected. They become mature cataract. Mature cataracts kind of push the iris forwards, can cause a lens-induced secondary angle closure glaucoma, what you call as a phacomorphic glaucoma. So now you know that the importance of identifying an acute angle closure glaucoma. When you see a patient, an angle closure a glaucoma patient in your vision center, make sure you record these, you find these findings, and try to instill an anti-glaucoma drop. Try to give the patient a Diamox if it is not contraindicated, if there are no allergies. Then you refer the patient. These are some of the very important things we should have to understand, because the protocols may vary between center to center, but referring an angle closure attack is quite important. Something which looks very similar to angle closure glaucoma or keratitis is going to be your acute anterior uveitis. So what is the important symptom which kind of quite unique for this? Like I said, similar to the acute keratitis, uveitis will also have glare. Glare, acute red eye plus glare is equal to, number one, acute keratitis, number two, acute anterior uveitis. Okay. The key point about uveitis is that something similar to scleritis, always look for systemic involvement. You see this picture, you should always look for systemic conditions, especially if the patient have a joint ache or back pain, oral ulcers. These are all important history you should collect from those patients. So getting a detailed history in uveitis is very important. And the patient will have recurrent episodes, frequent episodes. Acute red eye with recurrent episodes is equal to acute anterior uveitis, scleritis, episcleritis, and viral keratitis. These are 4 conditions where you'll have repeated attacks of acute red eye. What are the signs in anterior uveitis? Very, very simple. I'll just give you some salient points. When it comes to the eye, there will be redness, of course. What is more important is look for keratic precipitates, which is not easy to find on a torchlight, but only on a slit lamp you can find. If you can find on a slit lamp, it's great. Keratic precipitates are going to be on the endothelium. Okay, this will look like a SPK, so superficial punctate keratitis, like what Anita ma'am had presented, but it is not on the superficial part. It's more on the endothelium or the back part of the cornea. That's why it's called precipitates. Always look for AC reaction. Any trauma patient, any ulcer patient, any acute red eye patient, please look for anterior chamber reaction, look for cells, look for flare. I hope you might know what cells and flare means. Okay. In advanced conditions, you can see this kind of a lot of fibrinous membrane. You would have come across this kind of finding on day 1 post-op. After cataract surgery, there can be a dense FM or fibrinous membrane in the anterior chamber, which is quite characteristic. Now, that is a post-operative uveitis. Okay. Yes. Acute red eye plus hypopyon is equal to 2 conditions. Corneal ulcer, second is going to be anterior uveitis. Especially if the cornea is clear, you see a hypopyon, you see a red eye, think of anterior uveitis. Okay. What is the other condition which have hypopyon with clear cornea? That is going to be your acute endophthalmitis, which will come in a minute. Note this, in an acute angle closure glaucoma, the pupil will be mid-dilated, whereas in an acute uveitis, the pupil will be very small pupil. The pupil will be attached to the lens, back of the lens, okay, front of the lens. So the iris will go and attach to this front of the lens or anterior lens capsule. This is called a posterior synechiae, okay. And the patients can have a complicated cataracts also later because of a chronic uveitis. So like I said, always ask for systemic history. Whenever a patient is going to have an acute red eye, especially young male, here I've got an old male, but think of a young male with very painful red eye, okay? If they're going to have if they walk into the clinic with like a stooped posture, bent posture, ask for any history of chronic backache that can indicate ankylosing spondylitis. Just one example to show that why asking the history of systemic condition is important for an acute red eye. All right, now that's to do with the uveitis. Endophthalmitis, needless to say, it's a burning issue. All of us should know the importance of endophthalmitis. Ask for history of any cataract surgeries done. The patient will have hypopyon, like I said. The patient will not have a corneal ulcer, but they can have a corneal edema. Okay. Also look for any posterior chamber IOL status also for the patient. Injuries or trauma is quite varied. It's quite a vast topic, but I just want to tell that any patient presenting to you with a trauma, defective vision, refer the patient as early as possible. Okay, any mechanical trauma or even chemical injuries, it is important. A mechanical injury, we can't do much from a vision center perspective, but for chemical injuries, you need to irrigate, you need to give lots of water, try to clear off the chemical debris, chemical contents present in the eye. And understand, alkali are more destructive than acid. We may think acid burns the face, but in fact, alkali has much more destructive. And the important thing is, when it comes to the chemical injuries, please understand that the patient can have a white eye. They may not have a red eye. They can have a relatively white eye. Why it is white? It is white because the alkali or the acid is going to burn all the blood vessels. So the blood vessels will not have any congestion. There's not going to be any red eye at all. So white eye, when you have this kind of like a corneal ulcer-like picture, be very important. Always refer the patient as early as possible. Which is much more common in our region, where people use chunna or lime. Okay, any lime or any chunna getting into the eye can cause severe destruction because lime is an alkali. Like I said, alkali is much more destructive than acid. Okay, all right. So we have covered the important conditions which are going to be causing an acute red eye with defective vision. Now, just want to touch upon one important topic, that is scleritis. Like I said, in scleritis, always remember, scleritis patients will scream. Scleritis patients will scream. Never ever forget this statement in your life. So remember that, because that's important. But for that, the other disorders, the other diseases which has acute red eye without defective vision, you can treat if you feel it. Okay. For example, a foreign body of the conjunctiva or cornea, you can remove it, you can remove the foreign body in your vision center. I just want to give one pearl. A patient presenting to you with multiple corneal abrasions, each and every word is important. Multiple corneal abrasions. Look at my fingers, like a paint. It's like scratches on the cornea. And what is the first thing you should do? Always evert the lid. Evert the lid and look for the foreign body, because a patient can have a foreign body here on the upper tarsal conjunctiva, and they will have a corneal abrasions like this, like a paint. Okay, this is an important key message which I want to share. All right, now that ends with the acute red eye and the two important concepts, with defective vision, without defective vision. So for more understanding, if you want more details, please watch that video. You can download that mind map for free as well. Defective vision, I think we have another class tomorrow on evaluation of a sudden loss of vision, I believe. So I just want to just touch on it and go. Defective vision can be either gradual defective vision or a sudden defective vision. So of this, which is emergency, obviously it's going to be the sudden onset defective vision. Sudden onset defective vision, ask the patient, is it painful or is it painless? If it is painful, again, think of two things. Is the patient's eye is red or not? Is it with red eye, without red eye? If it is with red eye, can you recollect what are the conditions? Very easy. Again, sudden onset defective vision, patient having painful eye with red eye. We discussed them just now. All these conditions, the angle closure glaucoma, the acute keratitis, acute anterior uveitis, endophthalmitis, trauma, all these are going to be having a sudden onset defective vision. They'll be painful. They will have a red eye. Okay, this you all know. We discussed about them detail in the previous section we discussed. But remember this, a young female coming to you with the sudden onset painful defective vision, the pain is much more on extraocular movements. What is the diagnosis? Think of optic neuritis. Very important. The reason why I'm saying this, because in optic neuritis, the patient may not have a disc edema. You think it is neuritis, it's inflammation, so there will be a disc edema. I can take a fundus photo, I can prove that it is optic neuritis, but it is not. Sometimes the fundus can be normal, the disc can be normal. That is the interesting and most unfortunate thing for us, because it's one condition where neither you will see anything nor the patient will see anything. Both are blinded actually. You will not see what's happening there. So always think of optic neuritis. The simplest is to do a torchlight examination. The one weapon what you guys all have, what all technicians, what all eye care professionals have, is going to be a torchlight. That's one forgotten weapon for an ophthalmologist. But you guys are fortunate, you have the torchlight. Use the torchlight to your advantage. With torchlight, you can find RAPD. With torchlight, you can assess the anterior chamber depth. With torchlight, you can find whether the cataract is mature or immature cataract. Okay. So see in this picture, an optic neuritis patient can have a very important brain problem called as multiple sclerosis. So that's the beauty of eye professionals. We will be the first people who will diagnose something more dangerous. This one patient, a young female, she had optic neuritis, and look at the brain image. You can see all these white lesions. This white, nothing but brain damage. We can simply call it. This is multiple sclerosis, very important. So always understand relative afferent pupillary defect. Also check for color vision deficiency. Okay, these are all very sensitive indicators for optic neuritis. Now coming to sudden defective vision without any pain. Okay, so we discussed about sudden defective vision, painful, with red eye, without red eye. Now what are the painless sudden onset defective vision? Just want to give you this. Is it bilateral or is it unilateral? Okay, if it is bilateral, a patient coming to you like this, walk into the clinic, not maintaining eye contact. He's like searching for you, he's not maintaining eye contact. Sudden onset, bilateral. Think of these three. Cortical blindness, very, very important. Old patient having hypertension can have a stroke. A patient with a stroke can have this sudden onset. They can't see anything. This is another one condition where neither you can see anything nor they can see anything because fundus will be normal. The problem is the back of the brain. Okay. Any methyl alcohol poisoning, not ethyl alcohol. Ethyl alcohol is so common these days, but methanol or methyl alcohol can cause sudden onset, painless, bilateral defective vision. Okay. This is quite important. There's one important thing which I learned from Aravind. I remember Kausalya ma'am telling me this. When we see bilateral disc edema, okay, you see bilateral disc swelling, always take a blood pressure because a patient blood pressure can be 200, 120, and they can present to you with this advanced disc edema, what you call as a malignant hypertension. Please remember, it's one important message for your life. You see a disc edema, take blood pressure. Patient's blood pressure can be quite high. Okay. All right. Now that's with the painless bilateral. What are unilateral? Sudden onset. This may be somewhat advanced, but I just want to give you this. A patient coming to you with a unilateral, painless, defective vision, just sudden onset. Okay. Examine the fundus. Okay. Examine the fundus. What is the common condition you will see? You will see two important conditions. First going to be CRAO, central retinal artery occlusion. Second is going to be CRVO, central retinal vein occlusion. These two are going to be very important. Okay. So I've divided into these things. Do you see a pale area, which means you see white areas? Do you see blood spots? Do you see raised areas on the fundus? Raised means elevated. For example, a retinal detachment is raised. Okay. You see this? This is a retinal detachment, which is raised. Sudden onset defective vision, painless. Look for these raised areas, elevated areas. CSCR, fluid in the macula. These are all important conditions. Do you see a blood spot? You see a blood spot? Look for any vitreous hemorrhage. Okay. Look for the vein occlusions, central vein, retinal vein occlusion. This is CRVO. Okay. So the concept is, the message is this. I just want to end with this. You see a patient who is going to have a sudden onset defective vision, which is painless or painful, no matter what. Check for RAPD. That is very important. Number two, always do a dilated fundus evaluation. Okay. Just want to end with this. If you want more details, I can still continue, or you can watch this mind map explanation much more detail in the videos what I mentioned. Thank you.